Welcome everyone. I'm Danny Hammer. I'm a professor of pharmacoepidemiology at Oxford, and I will be moderating this session. I'm sorry there were some technical issues that have now been resolved. So I'm hoping we will have an uneventful event, an uneventful meeting from now on. We have most of our speakers online already, and I'm hoping that the rest will arrive as we speak. What we'll do is we'll go presentation by presentation. We'll take questions after each of the presentations. And for questions, please use the chat named Q&A, and I will be monitoring that for questions. The presentations will last for a maximum of 10 minutes each. And I will please ask the speakers to be to keep to time, and we will make it successful. So the first speaker, by the way, there's two Aislinn categories now. If your name is wrong, just hover over your name, click on the three ellipses, and you can change the name that appears on your screen. Okay, we're going to start. The first speaker is missing. I'm going to start with inviting Andrea to give her presentation, if that's okay, Andrea, when you're ready. If you want to unmute yourself and share your screen, we'll be delighted to hear what you have to tell us.
Hello. Okay, let me get PowerPoint set up. Are you guys seeing the whole screen now?
No, we're not seeing any screen yet.
Oh, sorry, let me share. Okay.
Yeah, we see your presentation now. So if you
Okay.
From the beginning.
So are you seeing the whole slide or the presenter view?
Presenter view.
Okay, so now we need to swap. Now whole slide? Are you seeing just one slide or all of them? I'm
seeing one slide, the one on disclosures.
Perfect.
And that's the cover one. Yeah, perfect. You're all set.
Okay, great. Thank you. So on behalf of my co-authors today, thank you for inviting us to present our work on predictors of critical care, mechanical ventilation, and mortality among hospitalized patients with COVID-19 in an electronic health record database. Here are our disclosures. So there is significant heterogeneity in the clinical presentation of COVID-19 infection, ranging from patients who are asymptomatic to those with severe disease.
I'm so sorry to interrupt you. I'm so sorry.
Yep.
Your screen is not in the full screen presenter mode.
Oh, okay.
So if you, sorry about that. I didn't mean to cut you off. Perfect.
Nope, perfect.
That is good.
So it is important to determine predictors of serious outcomes, as patients may decline rapidly after initially presenting with mild symptoms. Identifying predictors of serious outcomes may enable clinicians to deliver appropriate care to patients early, as well as to inform interventions to reduce risk of death. The goal of the study was signal detection. As such, the objective was to determine the demographic and clinical predictors associated with serious outcomes among hospitalized COVID-19 patients in a large EHR database that is representative of a geographically diverse US population. This study used data from Optum's EHR database, which consists of a subset of patients from Optum's EHR database with documented clinical care with COVID-19, acute respiratory illness, or COVID-19 testing. This database is updated biweekly and captures point-of-care diagnostics for the COVID-19 patient during initial presentation, acute illness, and convalescence. This was a retrospective cohort study among patients with COVID-19 infection between January and November 2020. Identification of COVID-19 was based on the presence of the ICD diagnosis code U071 and or the presence of a positive SARS coronavirus 2 viral test. Patients hospitalized with COVID-19 were identified among those with the presence of an inpatient healthcare encounter. Cohort entry date was the later of the date of confirmed COVID-19 infection or the date of hospital admission. Demographic characteristics were assessed on the date of cohort entry, and comorbidities were assessed in the 21 days prior. Vital signs, laboratory results, symptoms, diagnoses, and treatments during hospitalization were also assessed. The primary outcomes of interest were receipt of critical care, mechanical ventilation, and death. Receipt of critical care was identified by CPT codes. Mechanical ventilation was identified by CPT and ICD-10 PCS codes and included intubation, mechanical ventilation, and extracorporeal membrane oxygenation. Death was ascertained via linkage to the Social Security Administration's death master file or the presence of the death indicator in the structured EHR data, within all data available during and after hospitalization. Baseline characteristics were examined overall and according to outcome. Logistic regression models were used to estimate unadjusted and adjusted odds ratios and corresponding 95% confidence intervals for associations between the covariates and each outcome. Adjusted models included age, gender, region, race, and week of cohort entry. So there were over 393,000 patients identified with confirmed COVID-19 between January and November of 2020. Of these, a total of 56,996 patients were hospitalized, 11,967 received critical care, 9,136 received mechanical ventilation, and 8,526 died. The outcome groups were not mutually exclusive, and we observed quite a bit of overlap between the outcomes. For example, of the nearly 57,000 hospitalized patients, there were 3,025 that experienced all three outcomes. This slide presents the distribution of age among all hospitalized patients with COVID-19 overall, as well as among patients experiencing an outcome. Patients aged 60 years and older represented 56% of hospitalized patients, and a higher proportion of patients experiencing each outcome, including 86% of patients who died. This slide shows the distribution of sex. Females and males were evenly represented among hospitalized patients, but males comprised the majority of patients experiencing each outcome. Regarding the distribution of race, 59% of all hospitalized patients were Caucasian, 21% were African American, 18% were of other or unknown race, and 2% were Asian. A similar distribution was observed among patients who received critical care or mechanical ventilation, while 65% of patients who died were Caucasian. For ethnicity, 75% of hospitalized patients were not Hispanic, 15% were Hispanic, and 10% had unknown ethnicity. So this slide, along with the next two slides, present associations between baseline characteristics and receipt of critical care, which is in red, mechanical ventilation, which is in yellow, and death, which is in blue. Age was associated with all three outcomes, particularly death. Compared to patients 50 to 59 years of age, the adjusted odds ratio for death among patients 10 to 19 years of age was 0.02, while the odds ratio for patients greater than or equal to 80 was 7.61. Female patients were less likely to receive critical care, ventilation, or die compared to males, and African Americans were less likely to experience any of the three outcomes compared to Caucasians. We also estimated associations for ethnicity, but no clear patterns were evident. Comorbidities that were associated with higher odds of all three outcomes included diabetes, obesity, COPD, coronary artery disease, congestive heart failure, kidney disease, and liver disease, with the strongest associations being observed for kidney and liver disease. Asthma and hypertension were associated with higher odds of critical care and ventilation, but lower odds of death. This slide, along with the next few slides, present associations between clinical characteristics assessed during hospitalization and each outcome. Dyspnea and hypoxemia were positively associated with all three outcomes in adjusted models, with both showing the strongest association with receipt of ventilation. In contrast, cough was associated with lower odds of all three outcomes. All selected in-hospital diagnoses showed positive associations with each outcome. The strongest associations were observed for acute respiratory failure, with odds ratios of 6.30 for critical care and 8.55 for ventilation, and sepsis, which had an odds ratio of 4.14 for death. This slide presents the associations between D-dimer and lactate dehydrogenase in quintiles in critical care, ventilation, and death. Among all vital signs and lab tests examined, these two markers showed the strongest associations with the outcomes, particularly death, with an odds ratio for the highest compared to the lowest quintile of 6.07 for D-dimer and nearly 7 for LDH. All of the selected treatments were associated with higher odds of outcomes, with the exception of ACE inhibitors and angiotensin receptor blockers, for which the odds ratio was 0.84 for critical care and 0.57 for death. We found that African Americans were at lower risk of experiencing an outcome compared to Caucasians. Since the start of the pandemic, Blacks have been more likely than whites to contract and be hospitalized with COVID-19. Nonetheless, evidence suggests that once hospitalized, they may not have a higher risk of adverse outcomes. Although a recent study among Medicare beneficiaries did find that Black patients had higher rates of hospital mortality than white patients, the differences in rates were explained by differences in the hospitals to which Black and white patients were admitted. Hypertension was positively associated with receipt of critical care and mechanical ventilation, but inversely associated with mortality after adjusting for age and other demographics. Findings in this study are consistent with previous studies that have found hypertension to be common among adults diagnosed with COVID-19, but not associated with mortality in adjusted models. Thus, while there may be overrepresentation of hypertension among adults with COVID-19, it appears this association may be confounded by age and other covariates and possibly affected by treatment. With the exception of ACE inhibitors and angiotensin receptor blockers, we observed that many treatments received during hospitalization were associated with higher odds of serious outcomes. An explanation for this finding is that most medications, particularly those that were investigational, were only recommended for use among patients with severe disease. Limitations of this study include that the presence of a diagnosis code in the EHR data may not represent the true presence of disease, as the diagnosis code may be incorrectly coded or included as rule-out criteria rather than actual disease. We assumed that the absence of a diagnosis code meant the patient did not have the disease. This assumption may be a reason why we observed an inverse association between cough and serious outcomes. In a patient who is very ill, severe symptoms like dyspnea and hypoxemia may be much more likely to be recorded than minor symptoms such as cough. Furthermore, it is possible that some comorbidities and medications may not have been captured, as healthcare encounters with medical providers who did not contract with Optum would not be observed. In summary, the purpose of this study was signal detection. We identified many clinical characteristics that were associated with receipt of critical care, mechanical ventilation, and death among patients hospitalized with COVID-19. As more continues to be learned about COVID-19 by clinicians and researchers, future studies should move toward causal inference and focus on identifying the etiologic factors and mechanisms responsible for some patients experiencing more severe COVID-19 disease. Thank you for your attention.
Thank you, Andrea, for your presentation and for keeping the time. We are now open for questions. We have only 3-4 minutes. Please write your questions in the Q&A chat if you have any. In the meantime, Andrea, I was wondering whether you could elaborate a little bit on how you used index dates for the different medicines, because those are treatments that were started during the hospital admission, right?
Yep.
Like ACE inhibitors, for instance. And I was wondering if you could tell us a little bit how the index date was used in the assessment of the effects of those medicines.
Sure. This was essentially for the in hospital part. it was very much cross-sectional, where we didn't really look at the index date. It just, if a medication was administered during the hospitalization, then we counted it as, yes, that person received the medication, but we haven't teased out yet in terms of the date that the medication was administered versus the date that mechanical ventilation was started, or, death is more straightforward. But in terms of the other two outcomes. So I think that's the next step in our work, is trying to tease out more the time factor, and in terms of like getting the right direction of association.
Thank you. Let me see if there are any more questions. There's a question here asking how were the covariates distributed across race and ethnicity, and if you considered matching in your analysis?
Again, so we didn't look at covariates within race and ethnicity in this study, but that's a really great point. I think that's clearly one of the reasons why I think some Black patients are experiencing more outcomes, is there's a greater presence of comorbidities. We didn't look at this for this study. We have other studies ongoing where we're trying to tease out those relationships a little bit more. Thank you for the question.
Thank you, Andrea. I think I'm going to stop it there in the interest of time, and we can go to our next presenter. Thank you so much for your presentation.
You're welcome.
If you could stay until the end, please, that would be great.
Of course.
So our next presenter, which should have been first, but I skipped somehow, I apologize, Aisling. It's going to be Aisling talking about severe obesity is a risk factor for mortality in patients with COVID-19. Whenever you're ready, Aisling, the floor is yours.
Thank you, Danielle. Let's see, it should be, hopefully you can all see this now. Okay, well, thank you, everyone. I hope everyone's having a great first day of ICB. I know here in New England, we've been adapting our plans because of Tropical Storm Henri. I hope everyone's safe from it. I know our dean sent out a message today with fire trucks all around our building. And I know a lot of folks are struggling without power. So I hope everyone's well, and thank you. I'm going to present today a study we did looking at severe obesity as a risk factor for mortality in patients with COVID-19 hospitalized patients. These are our disclosures. The views expressed are those of the authors and not of the Department of Veterans Affairs. This study was unfunded, and these are our conflicts in terms of research funding, speakerships, and consultancies with industry. So when I was earlier on in the pandemic, when I was talking with critical care colleagues, a lot of them were saying that, if you look around the ICU, 7 out of 10, up to maybe 9 out of 10 patients in the ICU were obese. And not only that, but if they sort of expected those patients to die during the hospital admission, again, they were seeing a lot of obese patients dying from COVID-19. So when we looked at the literature on this, we actually saw a lot of conflicting findings, for anywhere from, only severe obesity affecting the development of severe COVID requiring hospitalization or mechanical ventilation, or having worse outcomes, so dying from COVID. So some studies showed severe obesity. Some studies were saying, nope, obesity wasn't associated with mortality. And those studies each had sort of limitations, as all studies do. But so as we were getting towards the end of the year and obviously anxiously anticipating the COVID vaccine, there was a lot of discussion about who was going to be prioritized, who these priority groups were going to consist of. And the way we would have optimally done it is study in every single population which factors were predictive of disease and death, and then applied that information to how we wrote these vaccination guidelines and how we define sort of underlying medical conditions. But when you really started to look around at some of these vaccination priorities, some didn't include any form of obesity, and some only included severe obesity. So we tried to see in our own population in the VA, what were we seeing in terms of the impacts of obesity or severe obesity. So the primary objective was to evaluate the impact of obesity on in-hospital mortality among patients who were hospitalized with COVID-19 in the VA healthcare system. The data source were VA COVID-19 databases that were curated pretty early on in the pandemic by the VA, but we actually supplemented those with a lot of the national databases that we usually work with that are created from electronic medical records, because these curated COVID-19 databases didn't include all the information we needed. The population we included were hospitalized veterans, and they had positive COVID-19 PCR tests. And the cohort selection dates were from March 2020 till November 2020. Obesity was assessed at the time of the index date. And in this case, our index date was either the earliest of the first positive COVID-19 PCR test date or the hospital admission date. So for about a little bit more than 60% of the patients, the COVID-19 test date was the same as the admission date. But for some patients, the test date occurred a day or two before the hospital admission date, meaning they were coming into the ER and then subsequently admitted. So the first analysis, our main analysis actually was looking at severe obesity, and we defined that as a BMI greater than or equal to 40. We used multivariable logistic regression, and we controlled for variables which were significantly associated with both severe obesity and mortality in order to identify whether severe obesity in and of itself was an independent predictor of in-hospital mortality. In sensitivity analyses, we looked at BMI greater than or equal to 30. And we also looked at sleep apnea. So that was something else that, talking to my critical care colleagues, is that a lot of these patients had pre-existing sleep apnea with use of CPAPs. So we actually looked at whether sleep apnea was independently associated with in-hospital mortality in hospitalized COVID-19 patients. And in our cohort, it was about 32% of our patients had diagnosed sleep apnea. These are our population characteristics. We included in that time frame, it was over 16,000 veterans hospitalized with COVID-19. The population reflects our VA population, which many of you probably know is mostly older males. The mean age was 68, mostly white. It was 95% white, mostly male, 95% white. And we were predominantly white. We actually saw lower percentages of white in the COVID-19 population. So overall, during that time frame, it was near 60%. A lot of times we see a lot higher percentage white in our VA studies. Although I will say a number of these demographics changed considerably from that first quarter of the pandemic, so say March 2020 until the last quarter of 2020. So that's September, October, November timeframe. And we have a different poster talking about the change in the demographics of the patients over time. Again, if we sort of look at the differences between inpatient mortality and inpatient survival, these are not differences that are unexpected. A lot of the patients who ended up dying had spent some time in ICU versus fewer. It was about 3/4 spent time in ICU among those who died, and only 1/4 in those who survived. Here's medical history. Medical history was assessed in the 2 years prior to the index date. The comorbidity burden, as we would expect, was a lot higher in our sicker veterans, our older, sicker veterans. They had a higher comorbidity burden, heart disease, diabetes, kidney issues, lung disease, sort of as we would expect. So across the board, the bold indicates that these were significantly different between those who died and those who survived. If we look at symptoms, and so, these are pretty decent numbers. So there's some small differences that, are statistically significant. I don't know how clinically significant they are when we're talking about, myalgias in 1.5% versus 0.8%. But actually to know out of this is, how veterans presented in that March to November timeframe. And it really was predominantly cough, shortness of breath, fatigue, and fever. Those were the most common symptoms experienced by patients. We saw very little of the runny nose, sore throat, the loss of smell, the loss of taste, again, was also very uncommon. So the symptoms in this older population were definitely cough, shortness of breath, fatigue, and fever. So in our adjusted analyses, looking at, so this again was severe obesity compared with no severe obesity. So the comparison group actually included those without any obesity and those with obesity in that 30.0 to 39.9 range. So when we looked at those with severe obesity, which was only about 8% of the total study population versus no severe obesity and adjusted analyses, the risk of inpatient mortality was 43% higher. And these were the variables included in the model, which included age, race, gender, if they had the ICU admission, hospitalization in the prior 30 days, cancer, Charleston comorbidity index, and non-alcoholic drug dependence. In sensitivity analyses, when we assessed obesity versus no obesity, so these then included patients with a BMI of 30 and higher. So it included those severe obesity folks, and then the lower end of the obesity spectrum versus no obesity. And we saw that in adjusted analyses, there was no significant difference in inpatient mortality between the groups. We controlled for similar variables and also hemorrhagic stroke, hypertension, and hyperlipidemia. That would have been from medical history. And in the last analysis, we looked at sleep apnea, the impact of sleep apnea on inpatient mortality. And again, we saw a non-significant adjusted odds ratio controlling for, actually, it ended up being the same variables. And so again, we didn't see a relationship here between sleep apnea and in-hospital mortality in the hospitalized COVID-19 patients. Limitations are that, right, as everyone I think is familiar with, the treatment recommendations were changing week to week during this time period, as was the COVID-19 epidemiology. And so we did not take into account the different treatment approaches that were being used over time, and that had subsequent improvements in mortality rates also. And again, the idea of the different populations being affected and their comorbidities, how it changed over time, we did not account for that in this analysis. So in conclusion, our national cohort of veterans hospitalized with COVID-19 from March to November 2020, severe obesity was an independent risk factor for mortality. And I think it plays an important role here. Again, when we were sort of looking at all this, it was the time of priority populations for vaccination. Now that priority populations have been vaccinated, of those who are willing to get the vaccine, we're really thinking forward to our unvaccinated populations that are at high risk of developing COVID-19, developing severe COVID-19, and having complications from COVID-19, including death. So I think the severely obese population will continue to be a really important population as we are expanding vaccination as much as possible. So thank you, everyone. I'm happy to take questions now.
Thank you so much. So there is a question that I can see here. I'm going to read it for you from Hannah Gerlovin. It says, were there any restrictions on the timing between first positive PCR and hospital admission? Also, given that ICU admission is in the pathway to mortality, how did you account for this in your analysis?
So I think it was 3-day mark. So we were trying to account for patients who may have come in, gotten a test, but weren't acutely sick right away, sent back home, and then coming back in within a short time frame. So we wanted to include a short time frame of when the PCR test may have been given, and then when they were hospitalized. So we had a 3-day cutoff. Again, it was the vast majority were either on the day of hospitalization or the day before. So indicating when they come in, sometimes through the ED, the emergency department, and they're not necessarily admitted until the next day. And sorry, the second part was, I'll pull up that Q&A. Oh wait, I can't see. Given the ICU admission, of course, is in the pathway. How do we account for this? So we did not assess the temporality between ICU admission and time of death. So we did not look at how many days from admission were they in the ICU. It was sort of the presence or absence of ICU admission that we controlled for. I think I saw another question. So we didn't control for intubation at this time. So we've been working on obesity and intubation. No, we didn't have all of our scores set up, which includes the intubation, mechanical ventilation, and whatnot. So we did not control for intubation in the analysis either, but that's a great point. Thank you.
Maybe last question, and we'll.
There's been published evidence for patient selection for ICU and COVID-19. Did you consider analysis. So again, it was the presence or absence of ICU. Something that we could do down the road is looking at subgroups within the ICU patients to seeing how they fared, which again, I'm guessing changed over time as we had a better sense of how to manage these patients. Again, this was more of an idea of talking about what that risk of mortality may be. It may not, right? We may not have the exact effect estimate, but we pretty consistently are seeing that mortality is associated, or sorry, obesity is associated with worse outcomes. And that's an important population to get vaccinated.
I was myself wondering, why did you choose to go for this strategy of backwards elimination when you were thinking of adjusting for confounders? That's a somewhat controversial approach, right? To adjusting for covariates in this type of analysis.
Yeah, so I think, so more than anything is we came up with our list of factors that were going to be associated with both the main independent variable interest, which is severe obesity, and then in the analysis of obesity and then sleep apnea with the mortality outcomes. And so trying to get to a model where we're controlling for factors that are confounding in the data is the approach that we took to this versus sort of an a priori list of presumed confounders.
Okay, thank you so much, Leslie. We'll cut it there. I'm going to ask the next speaker to introduce herself. This is Kate Anderson, utilizing the National COVID Cohort Collaborative to evaluate risk of serious outcomes with COVID-19 among chronically immunosuppressed persons.
Thank you so much. Good morning, good afternoon, or good evening. On behalf of my co-authors, as well as the founders and contributing sites to the National COVID Cohort Collaborative, or N3C, it is my pleasure to present this work utilizing the N3C to evaluate risk of serious outcomes with COVID-19 among chronically immunosuppressed persons. No direct funding was received for this work, and you'll see our relevant financial disclosures here. There are plausible mechanisms by which chronic immunosuppressive drugs could affect COVID-19 outcomes while hospitalized. It's possible that the chronic immunosuppression is beneficial in preventing a hyperinflammatory response, and it's also possible that chronic immunosuppression is harmful, as this is consistently identified as a risk factor for COVID and other viral infections. However, emerging evidence does not suggest a strong association. Others have reported non-significant effects or small hazardous effects, as have we using the registry of adults hospitalized within the Johns Hopkins network. I'll also note that there were no increased risks found in the Middle Eastern respiratory syndrome or in the SARS of 2003 outbreaks. So there is mixed evidence regarding the impact of immunosuppression and immunosuppressive medications on COVID-19 outcomes. And it is further unclear whether these associations vary by medication class. We conducted a retrospective cohort study using the National COVID Cohort Collaborative, an electronic health record repository. Our cohort was selected among the 2 million COVID patients, and we identified 222,575 adults that were hospitalized with COVID in one of 42 health systems in the United States from January 2020 through June 2021. The exposure that we considered here was immunosuppression present at admission, and we're not considering people who are starting these drugs for the first time for the management of COVID. We considered immunosuppression in 3 broad buckets. First, as defined by the WHO's ATC grouping L01, anti-neoplastic agents. We also considered L04, selective immunosuppressants, and oral glucocorticoids. We further examined these in subclasses. We used select rheumatologic drugs such as IL, JAK, TNF inhibitors, and other rheumatologic drugs such as leflunomide. We separately considered antimetabolite drugs like azathioprine, calcineurin inhibitors, mycophenolic acid, and other mycophenolate derivatives most commonly used for solid organ transplant recipients. We considered several different types of cancer therapies, including anthracyclines, checkpoint inhibitors, cyclophosphomides, protein kinase inhibitors, targeted therapies, and others. We looked at rituximab, and importantly, we separated rituximab into people who had a concomitant autoimmune diagnosis separate from people who had rituximab with a concomitant cancer diagnosis. And then lastly, oral glucocorticoids. We considered two outcomes that I'm going to show today. First, invasive mechanical ventilation, for which we used Fine and Gray's proportional subdistribution hazards models to account for the competing risk of death. Secondly, we evaluated the risk of in-hospital death using Cox proportional hazards models. We truncated the first and 99th percentile of the propensity score, and we used 4-to-1 nearest neighbor matching with a tight caliper. We implemented doubly robust adjustment for remaining imbalances and updated the propensity score and the imbalance set for each subgroup and sensitivity analysis. Overall, 7% of adults that were hospitalized met our definition of immunosuppressed, most frequently with prednisone, tacrolimus, or mycophenolate. The immunosuppressed adults were comparatively older, more often female, and they were less likely to be Hispanic or Latinx, which is one of the groups that is suffering disproportionate outcomes as a result of systemic racism in the United States. Not surprisingly, the immunosuppressed adults also had a greater prevalence of comorbidity. The overall effect of any immunosuppression, we did see a statistically reduced risk of mechanical ventilation. So it was 9% for immunosuppressed adults as compared to 6% in unadjusted analyses. But once we accounted for the demographic and clinical differences between the groups in our matched cohort, we did find a hazard ratio of 0.89. We did not find differences in the risk of in-hospital death. There was a large difference in the unadjusted analyses, 14% versus 9%, which was attenuated in the matched cohort. We separately considered these medications in 15 broad buckets as discussed earlier. And importantly, none of these classes were associated with an increased risk of invasive ventilation. The x-axis here is a hazard ratio with the dotted line representing 1 or a null effect. And you'll see the medication classes that are represented with black bars are those that had a non-statistically significant effect. However, the orange bars are the medication classes in which we found statistically significant decreases in the risk of invasive mechanical ventilation. And these were noted with glucocorticoids, calcineurin inhibitors, cyclophosphomides, as well as some selective immunosuppressants and some cancer therapies. For the risk of death, we found only one group was associated with a decreased risk, and these were the JAK inhibitors. Most of the medications that we studied had non-significant effects, with the exception of rituximab, which for either a rheumatologic or a cancer indication had a large and statistically significant increase in risk. I'll also point out anthracyclines, which just crossed the null effect, but has a large magnitude of effect and is perhaps warranted for caution. The results of our sensitivity analyses were generally consistent. We varied our exposure definition by restricting to glucocorticoid information with dose available. The majority of medications in the N3C do not have dose available, so this significantly restricted our cohort. We also varied our outcome ascertainment by restricting the cohort to people who were in the hospital for at least 2 days, because people who left within 1 day, either by discharge alive or death, were perhaps different. And we also varied our ventilation onset definition if we didn't have a precise date of onset. We varied our covariate ascertainment first by restricting the cohort to people who had at least one prior encounter in the healthcare system, meaning they had the potential for greater look back and covariate ascertainment. We further restricted the cohort to people who had an available zip code where we could match zip code level socioeconomic variables. And then lastly, we considered laboratory measures and vital signs. Our findings regarding immunosuppressive therapies extend the results of our earlier work and that of others examining the association between the use of these medication classes and COVID-19 outcomes. Rituximab is a chimeric monoclonal antibody that powerfully interferes with antibody response to infection and can lead to prolonged viral replication. It is therefore not surprising that we found null effects for ventilation and an increased risk of death, given the impaired antiviral humoral response. In conclusion, among this cohort, with the exception of rituximab, there was no increased risk in ventilation or death for the rheumatologic, anti-neoplastic, or anti-metabolite therapies examined. Our sample size was large enough to separately consider a variety of drug classes with distinct molecular mechanisms of action, including the targeting of B cell versus T cell mediated immunity. Our results add to a growing body of evidence suggesting the overall safety of several products against the backdrop of continued COVID-related morbidity and mortality. These findings are important because of how commonly these products are used and ongoing questions regarding the degree to which they increase risks of poor outcomes among individuals who are hospitalized with COVID. I'd like to acknowledge the data source that we use, and with that, I'll take your questions. Thank you.
Thank you so much, Kate. There's a couple of questions already. The first one is how do you believe what was your reliability in capturing baseline immunosuppressant therapy, especially when some of these treatments were prescribed far outside your healthcare system and when there was movement of patients, when there was shortage of ICU beds and so on?
Yeah, this is definitely something that we were concerned about. The N3C, as I mentioned, we looked at 42 different health systems. And so there's a variety of drug reconciliation records that were shared, current at admission. And we considered this in sensitivity analysis, I'd say, by having the look back concerns that we have. But it's possible that we did misclassify people because that information wasn't available in the record.
Thank you. The second question on screen says, can you explain why you chose competing risk approaches for ventilation as an outcome?
Sure. So with invasive mechanical ventilation, there's a competing risk of death because if people die, they're no longer at risk of ventilation. And in particular, there were periods in the pandemic where there were gaps in access to the mechanical ventilation in the United States. And there's also the possibility that people have what's called a do not resuscitate order or advanced directives in place. The N3C does not contain that information. And so we didn't want to ascribe people as not being at risk of the outcome if they perhaps had a DNR order in place and they died rather than receiving invasive ventilation.
Again, another question that I read now in the general chat, and I'll remind all our fellow colleagues to ask your questions in the Q&A chat, in the dedicated Q&A chat, otherwise we'll miss them. The question says, how did you handle polypharmacy in your analysis? Yeah,
it's common, in particular with the solid organ transplant patients. We see most of them have the cluster of 3 drugs. We considered each drug separately in this analysis.
Okay. Another question that somebody's asking here is, have you looked at subgroups of patients with autoimmune conditions or even individual autoimmune diseases and those with malignancies? These populations might have very different risks for death in the first place.
Yeah, so here we defined immunosuppression based on medications, not based on diagnoses, in part because we're pharmacoepidemiologists and that's our area of expertise more so than the clinical questions. I think there's important teasing out to still be done, but given the look back data was limited, we were concerned about using diagnoses and instead used medications.
Thank you, Kate. A question from myself, because I don't see any more questions on the screen. So some of the medicines you observed had a protective effect rather than a deleterious effect, right? And of course, you know that there are some immunosuppressants like tocilizumab or corticosteroids are being used to treat the condition. Mm-hmm. Do you think the protective effects you observed were true protective effects, or do you think they are, residual confounding or something else?
Yeah, so there's no way to know for sure. Something we hear consistently from our clinical colleagues is that perhaps these patients on these medications were hospitalized earlier and at a lower threshold because they're perceived to be at a higher risk. And so perhaps the patients that are on immunosuppression aren't as sick as the comparators because they're being hospitalized earlier in the trajectory. I think it's also possible that these medications are in fact working. This is something that our group is looking at if response to dexamethasone, for example, is blunted in people who have chronic immunosuppressive medications because their immune system has developed some sort of a tolerance and some familiarity with these medications. Okay.
No more questions from the audience and no more questions from me. That was a great presentation. Thank you so much. I'm going to introduce, well, let her introduce herself. Professor Soko Satoguchi is going to take over chairmanship of this session going forwards. Thank you, Soko.
Thank you, Danny. Hi, everyone. Soko Sadaguchi from Rutgers University. So the next speaker is Dr. Jessica Jalbert. She's going to be presenting a paper called Incidence and Risk Factors for COVID-related Urgent Medical Visits Among U.S. Patients Diagnosed with COVID-19 in the Outpatient Setting.
Great. Thank you, Soko. Can you see my screen?
Yes.
Okay, excellent. Well, thank you so much.
You want to make it to a presenter mode, Jessica?
Oh, yes. Yes. Good.
Great.
All right. Well, good morning, good afternoon, good evening, everyone. So my name is Jessica Jalbert, and I'm going to be presenting on our study looking at the incidence and risk factors for COVID-related urgent medical visits among patients who are first diagnosed with COVID in the outpatient setting in the US. So here are our disclosures. So I work at Regeneron, and all the authors also are working at Regeneron. In terms of a background, so as everybody knows, infection with SARS-CoV-2 can lead to hospitalization or death. However, most people are actually not first presenting in the inpatient setting, they're first seen in the outpatient setting. Since the beginning of the pandemic, we've developed some treatments that are effective at treating SARS-CoV-2 and in reducing, which reduces the risk of hospitalization and mortality for these patients who are treated in the outpatient setting. However, the treatment is most efficacious when it's provided early. So especially early on during the pandemic, a lot of information that was coming out regarding the natural history of COVID-19 was coming from patients who were treated and seen in the inpatient setting. And there was very little information regarding patients diagnosed with COVID in the outpatient setting. So that presented some challenges for clinicians who needed to understand who's going to be at highest risk of the disease. So essentially, what we decided to do is to estimate the incidence of COVID-19 related urgent medical visits and identify the risk factors associated with these visits. So this could inform both patient management for patients who are seen in the outpatient setting, as well as resource allocation, including treatment. So the objective of this study was to characterize patients who were initially diagnosed with COVID-19 in the outpatient setting, and then to estimate the 30-day incidence of subsequent COVID-19 related urgent medical visits and identify the risk factors associated with that outcome. In terms of the data source, so we use the Optum COVID-19 EHR database. It's a de-identified patient level data set. It was created during the pandemic for us to better study and understand COVID-19. The data are primarily from integrated healthcare delivery networks, and they include patients who were either tested for SARS-CoV-2 and have a negative or positive test, or who were diagnosed with COVID-19, and include essentially everything that you would expect from an electronic medical record database. In terms of the study design and population, so we conducted a retrospective cohort study. Our study population of interest included patients who were diagnosed with COVID or who had a positive SARS-CoV-2 test in the outpatient setting between June 1st, 2020 and December 9th, 2020. We selected either the first diagnosis of COVID-19 or the first SARS-CoV-2 positive test as the index date. And we wanted to make sure that they didn't have previous, that it was the first time that they were diagnosed. So we excluded patients who had a prior COVID-19 diagnosis, other coronavirus diagnosis, or had any evidence of having a positive SARS-CoV-2 test previously. We included patients who were members of an integrated healthcare delivery network and who at least had one health encounter within the past 2 years prior to the index date, and then we restricted our study population to adults. So we followed up patients from the index date until the end of the study period, the outcome or mortality, whichever one came first. Our outcomes of interest included, we looked at 2 different outcomes of interest, which conceptually were COVID-19 related urgent medical visits within 30 days of the index date. So the first was kind of a broader net where we were looking at COVID-19 related urgent care, emergency room visits, or hospitalization. And then we also looked at COVID-19 related hospitalizations. To make sure they were COVID related, for the urgent care and ER visits, we required that they had a COVID-19 during diagnosis during the encounter. And for the hospitalizations, we made sure that they also had a primary admitting diagnosis during the encounter. Now, the results, in the interest of time on the next slides, I'm going to focus primarily on the COVID-19 related hospitalizations. So the risk factors that we were interested in looking at were primarily those that were identified by the CDC as increasing the risk of severe COVID-19. And then we also did additionally, we did a literature search to see if there was anything that was potentially missing off that list. So we looked in terms of risk factors at demographics, at BMI, at comorbidities, and then we also looked at what I call situational. So essentially, where the patient was diagnosed in the outpatient setting, where in the country, when in terms of when during the pandemic, and then we also looked at previous prior healthcare resource utilization. Oops. So in terms of the statistical analysis, so we looked at patient characteristics on the index date, and we describe them in terms of their demographics and clinical characteristics and comorbidities. Because competing risks, because mortality is also a competing risk here for a risk of subsequent healthcare resource utilization, we use the cumulative incidence function to estimate the incidence and 95% confidence intervals for our outcomes. And then we also use the fine-gray subdistribution hazard model, which accounts also for competing risks of mortality, to derive the adjusted and unadjusted hazard ratios for each of our risk factors for our outcomes. So here are the results. So firstly, we identified a little less than 210,000 patients who were either diagnosed with COVID-19 or tested positive for SARS-CoV-2 in the outpatient setting. We're looking at a population of mean age a little under the age of 50, about 60% women, predominantly white, so 80% were white. In terms of geographic distribution, so the Optum COVID data set actually has more of a representation of centers within the Midwest and Northeast, which is reflected here in terms of the distribution of our patients. When we looked at the index month, we also are finding that the majority of our patients are essentially coming from the third wave of the pandemic, so mainly from the late fall to beginning of the winter. If we look at in terms of the BMI, we're looking at a patient population that is on average obese, and then I've selected here a few comorbidities. I guess the most notable one is hypertension, with about 30% of our patients having hypertension. So this is, as I was alluding to on the previously, so we're looking specifically at patients, the outcomes for the COVID-19 related hospitalizations, and I'll show you for the rest of the urgent medical visits a little later. But what we see here, this is the cumulative incidence of COVID-19 related hospitalizations. We're seeing that essentially by 30 days, about 44% of our patients did get hospitalized. And if you essentially look at the shape of the curve, you're seeing that a lot of the activity is essentially within the first 10 days of the index date. So here we're looking at the 30-day instance of COVID-19 related hospitalizations within 30 days of a SARS-CoV-2 positive test or a COVID diagnosis. And I'm focusing here just on the key risk factors, so where essentially we found that there was the highest incidence. So where we found the highest incidence was actually in patients in older age groups. So by and large, patients who were aged 85 years and over had the highest incidence of 30-day COVID-related hospitalizations. In terms of race ethnicity, so we're looking at non-Hispanic Blacks were more likely to be subsequently hospitalized than other minorities or whites. And then when we look essentially at BMI, we also see from normal weight to morbidly obese an increased incidence in the likelihood of being subsequently hospitalized. I've only selected a few comorbidities here where we were seeing the highest incidence within 30 days of the index date, and those are in CKD, chronic obstructive pulmonary disease, and cardiovascular disease. And then we also saw essentially some high incidence in patients who had some prior, healthcare resource utilization relative to baseline, so prior hospitalizations or baseline ER visits. So this is a forest plot that is essentially looking at the adjusted hazard ratios for the individual risk factors for 30-day subsequent COVID-19 related hospitalizations. And so what it is that we see is, if you look here at the top, this is age. So what we see is that, again, with increasing age relative to younger patients, those patients are at higher risk of being hospitalized for COVID after an outpatient diagnosis. We see a slightly higher risk among men versus women in terms of race. Relative to white people, we see that people of other racial or ethnic minority groups are more likely to be hospitalized. We see some variability within region. One thing I wanted to highlight here is whether or not if the patient was seen first in the emergency room or the urgent care center, that patient was more likely to be subsequently hospitalized. So these are looking at the index months, a lot of variability in the index months. In terms of baseline hospitalization, this is another very strong risk factor for subsequent hospitalization for COVID. Interestingly, what we're seeing is, so these were the comorbidities, CKD, COPD, CVD. These were the comorbidities that had a high crude incidence of being subsequently hospitalized. And we see that essentially, yes, they are still conferring a risk, but certainly not on the scale that we're seeing for age or even for BMI, which is the next risk factor that I'm moving to. So for BMI, compared to patients who have normal BMI, again, increasing BMI was associated with increased hazards of hospitalization. Pregnancy was also associated with increased risk of hospitalization. And then in terms of the comorbidities, diabetes, particularly having a HbA1c value greater than or equal to 7, was associated with an increased risk of hospitalization. So in the interest of time, I can't walk you through all of our findings for COVID-related urgent medical visits, which include emergency room visits and urgent care visits. But what we can see is is obviously the absolute incidence is larger. So we're looking at an incidence of about less than 10%. By 30 days, the patients are coming back to some urgent, or being seen either in the ER setting or the urgent care setting or hospitalized. But we're seeing very similar patterns to what we were seeing with the COVID-19 hospitalization. That is, the patients, if they're going to be seen again, tend to be seen within the first 10 or so days of the index date. And then just briefly, I just want to say that, the majority for when we were looking at the incidence of COVID-related urgent medical visits, what we're seeing by and large is very, very similar to what we were seeing for the COVID-19 related hospitalizations in terms of those subgroups for which the incidence rates were the highest, as well as the risk factors that were the strongest. So in terms of limitations, there are numerous. So the data represent very early experience up to December 2020. And so obviously the situation is changing very rapidly. And so may not be generalizable to, for example, the situation that we have now, including with the new variants. We restricted to patients who are members of integrated healthcare delivery networks, but it doesn't mean necessarily that we've captured all of their urgent medical visits. We didn't have data on symptoms or viral load or virus variants. Those were not reliably captured. And as I've alluded to previously, the data were national, but not nationally representative. And so some regions were essentially underrepresented within the database, notably the South and the West. So to conclude, among patients with COVID-19, among patients who were diagnosed with COVID-19 first in the outpatient setting, the incidence of 30-day COVID-related urgent medical visits was quite low. So we're looking at less than 4% at 30 days for COVID-related hospitalizations and less than 10% for COVID-related urgent medical visits. The risk of 30-day COVID-19 related urgent medical visits was highest in the oldest patients and also among patients with certain comorbidities. And so it is our hope that the awareness of some of these risk factors and the results of the study can help healthcare providers potentially identify those patients who are at highest risk and intensify their clinical management of those patients. Thank you.
Thank you very much. Very clear and organized presentation. So I see 2 questions in Q&A. Let me ask one question before I go on to these. Is your patients who sort of base cohort of patients who tested outpatient, does this include also patients who tested outside of medical facility like pharmacy, sort of stores or other places, or limited to healthcare system?
Yeah, my understanding is that it's going to be pretty much limited to the healthcare system, right? So the data that come from your Duane Reade are not going to necessarily feed in very well into the electronic medical records. So that's correct. So the data from the tests are going to be probably those that are going to be conducted on site.
Okay, thank you. So then moving on to the questions in Q&A, seems like current smoker is less likely to be hospitalized. Can you have more comment on that?
Oh yeah, so basically talking about yes, so the current smokers, yeah, we really kind of struggled regarding that data point. It's unclear. I think it was unclear in the literature whether or not this was truly affected, if this was truly a risk factor for subsequent hospitalization among patients with COVID. I think the verdict is still out on that. I don't have a clear answer to that. I think that was a mystery for us as well.
Okay, thank you. And then the next question says, not sure if I missed it, but did you look into risk factors for readmission?
No, we didn't look at factors for readmission. That's the next piece of work, that we're looking at. So we are looking at essentially what are the factors, what's the incidence of readmission, what are the risk factors of readmission for patients who've been discharged alive from a COVID-related hospitalization. That's an interesting question to look at. I guess that ties into a lot of long COVID questions as well, and the impacts, the long-term impacts of COVID on health, on the patient's health.
Yeah, is your data actually suitable for that question? Do you have a good follow-up data readmission? Because many healthcare system data, EHR data, it's limited to their own system.
Yeah, that's right. So we did subset to patients who are parts of the integrated healthcare delivery network. So these are like the Mayo clinics and the Geisingers, right? So we do hope, so we do hope that we're having some good follow-up on those patients. I mean, of course, it's not perfect, so we are aware that we're probably missing some events. But we are, we're hopeful that it's not the majority of those events, right? So I think it's pretty good capture.
Okay, great. Next one, were there any missing data? If so, how did you handle them?
Yeah, so there were some missing data. I mean, it's like a lot of it is like claims, right? So you don't know what you don't know, but we did have information. I remember that I saw there was a question earlier on regarding missing race. So yes, so essentially we had something like 10% missing race ethnicity. And then when it came to the risk factors, we essentially just created a missingness category, included in the model, which is not included in this forest plot because the forest plot already has tons of data in that.
Thank you.
Yeah.
The last question, I think it's in the general chat box. And please, everyone, put your questions into Q&A box because I caught it. I'm sorry if I wasn't paying attention. Did you look at the different types of COVID, Delta type, etc.?
Yeah, unfortunately, that's not something that's going to be that we had. Well, I mean, it predates a lot of the discussion regarding the variants, right? So this is data from June to December 2020, and so we didn't. So it was still, COVID wild type pretty much by then. I think there was, I think that the other variants are starting to emerge kind of more in 2021.
Thank you. I think great sort of discussion. Thank you, everyone. We'll move to the next speaker. Thank you, Jessica.
Right, thank you.
And then I think we're still missing the fifth speaker, correct? Danny or?
Yeah. The first speaker didn't arrive. So you can
Okay,
go.
so we'll move on to the last speaker, not last, not least, Catherine Kurganski. Apologize if I mispronounced your name, but she's presenting convalescent plasma therapy and mortality among U.S. Among U.S. Veterans hospitalized with non-severe COVID-19. Thank you.
Great, thank you so much. Can you see my slides and hear me all right?
Yes.
Great, thank you. So hello, everyone. I'm Catherine Kurganski, and I'm here representing the Boston VA Epidemiology Center. I was the lead data analyst and co-first author on this project. I'm excited to share with you the work that we've done looking at convalescent plasma therapy in US veterans with non-severe COVID-19. Thank you for this opportunity. We have nothing to disclose. Convalescent plasma was widely used to treat COVID-19, but its effectiveness remains unclear. Convalescent plasma comes from donors who have recovered from COVID-19. The plasma contains antiviral and anti-inflammatory components that offer the potential to provide passive immunity to recipients. The antiviral properties of convalescent plasma are expected to be most effective during the initial viral replication phase of the disease, which peaks during the first week of infection. Here is a brief summary of some of the key papers that have examined the effectiveness of convalescent plasma. Most randomized trials were small and reported imprecise and inconclusive effect estimates for mortality. On the other hand, Many of the observational studies demonstrate a lower risk of mortality in patients treated with convalescent plasma relative to those who are not treated with plasma. Given the inconclusive and varied results from prior studies, we sought to assess if early treatment with convalescent plasma reduces the risk of 30-day mortality among SARS-CoV-2 positive United States veterans with non-severe illness. We chose to emulate a target trial due to urgency around understanding more about COVID-19 treatments and given the extensive electronic medical record data that we have access to in the VA healthcare system. A target trial is the hypothetical pragmatic randomized trial that we would have liked to conduct, but could not due to constraints in time and resources. Observational data can be used to emulate the target trial. I'm going to start by showing a summary of the results from our analyses and then describe the methods that we used to get there. We found that early transfusion with convalescent plasma did not reduce the risk of 30-day mortality among SARS-CoV-2 positive veterans with non-severe illness relative to those who were not treated with convalescent plasma. I will come back to our findings later. Now, I will outline the specifications of the protocol components for our target trial. In the trial emulation, we tried to match components as closely as possible to the components of the actual target trial. We developed this strict set of eligibility criteria. In the actual target trial, a clinician would be responsible for evaluating these criteria. However, for the emulation, we assessed the same set of criteria using the data from the VA electronic medical record system. The criteria in bold were used to identify patients who were not severely ill with COVID-19, as that was our specific target population. The treatment strategy for the target trial would be either receipt or no receipt of convalescent plasma transfusion. The outcome of interest would be 30-day mortality, and follow-up would begin at the treatment date or time zero, which must fall within 2 days of the first date on which a patient was hospitalized in a VA medical center with a positive SARS-CoV-2 test. All of these protocol components remain the same in our target trial emulation. In the target trial, patients would be randomly assigned to a treatment strategy. However, in the emulation, we classified patients according to the treatment strategy consistent with their data and attempted to emulate randomization through adjustment for baseline covariates using inverse probability weights. These are the a priori baseline prognostic factors that we included in our inverse probability weights. We focused on variables that clinicians may assess when determining whether to treat a COVID patient with convalescent plasma. The analysis of the target trial emulation was identical to how the target trial would be analyzed, except that patients could be included on each day of eligibility rather than on only a single day of eligibility. For example, Bob met eligibility criteria on days 0 and 1 and was included in trials on each of those days. On day 0, he was in the non-convalescent plasma group, to which he contributed 20 days of follow-up until death. On day 1, he was in the convalescent plasma group, to which he contributed 19 days of follow-up until death. Since he was treated with convalescent plasma on day 1, he no longer met eligibility on day 2 and could not be included in a trial on that day. Sue met eligibility on day 0, 1, and 2. She was never treated with convalescent plasma, so was included in trials on all 3 days in the non-convalescent plasma group. She contributed 30 days of follow-up for each trial since she did not have the mortality outcome. Estimates were pooled from each of the 3 nested sequential target trials. The risk of mortality was estimated from a pooled logistic regression model that contained a time-varying intercept of the spline, an indicator for the treatment group, and an interaction term between time and treatment, as well as adjustment for the 23 a priori baseline prognostic factors via inverse probability weighting. We calculated confidence intervals through non-parametric bootstrapping with 1,500 samples. We started with 14,384 SARS-CoV-2 positive veterans who had an admission to a VA medical center. After applying all eligibility criteria, we ended up with around 5,000 eligible patients who were included in about 11,000 trials. This was because patients could be included in up to 3 trials as long as eligibility was met. Among these patients, 402 were included in the convalescent plasma group and 10,867 were included in the non-convalescent plasma group. About 10% died in the plasma group and about 6% died in the non-plasma group. Here are the baseline characteristics by treatment groups. Age, sex, and ethnicity are comparable between groups, but there are major differences with respect to race, region, smoking, COPD, diabetes, and hypertension. Patients who received convalescent plasma appeared to be sicker since they were at least twice as likely to be in the ICU, have glucocorticoid or remdesivir use, and have systemic inflammatory response syndrome. As shown on this left plot, the imbalance seen before waiting, represented by the blue squares, was reasonably well balanced after inverse probability weights were applied, which are represented by the red circles. Here is the estimated cumulative incidence of 30-day mortality. The convalescent plasma treatment group is represented in red and the non-convalescent plasma group in blue. The shading represents the confidence intervals that were generated from bootstrapping. As you can see, after weighting baseline confounders, we did not observe a difference in the risk of 30-day mortality for those treated with convalescent plasma relative to those who did not receive plasma. Both treatment groups had just over 6% risk of mortality. The 30-day risk difference was only 0.3%, and the 30-day hazard ratio was only 1.04. The results of our analysis are compatible with those of the recovery trial, which was the largest randomized trial of COVID-19 convalescent plasma. This suggests that the emulation of our trial was successful. Results from many observational studies may contrast with ours due to differences in causal questions and potential biases. Our study had many strengths. It is the largest observational study assessing the effectiveness of convalescent plasma. Additionally, within the VA, we have access to vast amounts of electronic medical record data, which allowed us to maintain the explicitly specified target trial protocol components throughout our emulation. This helped to minimize biases and other methodologic issues that are common in observational studies. Although our study had many strengths, one major limitation that was that we did not have access to titer data for the convalescent plasma transfusions. In conclusion, our analyses do not support the use of convalescent plasma therapy in reducing mortality among hospitalized non-severe COVID-19 patients. However, further research is warranted to assess the effect of convalescent plasma on progression to severe disease and to better understand effective plasma dosing. Here's a reference for our recently published manuscript in the Journal of Infectious Diseases, and additionally here are references for the other studies that I've referred to throughout this presentation. And finally, I'd like to thank my colleagues and collaborators from the VA Boston Healthcare System and VA Boston Epidemiology Center, from the VA Causal Methods Core and Harvard Causal Lab, the Seattle VA Epidemiologic Research and Information Center, the VA Office of Research and Development, and the VA Central Office. Thank you very much.
Thank you, Catherine. Very nice presentation.
Thank you.
I don't see any questions yet. Let me start then. So you assessed 30-day mortality as an outcome. Were you able to capture fully, or did you have any censoring on the patient?
We did not censor. So the VA captures mortality data from many different sources. And so we made the assumption that if the patient died within that 30-day period, that would have been captured within the VA data. And there's also a lag time in the capture of VA data. So we made sure to end our follow-up after sufficient time to account for that lag.
Okay, that makes sense. There's one question. How did you select up to 3 trials per person? What would the result have been if you chose just one? Just the first?
Sure. So we believe that if we just chose the first trial, it would be similar results. The reason we pooled the results from the 3 trials was for statistical efficiency. We also chose the 3-day window because we wanted, prior studies have suggested that convalescent plasma was most likely to be effective within the earlier period following a positive SARS-CoV-2 test or hospital admission. So that's why we limited to that short window.
Another question from me while we're thinking. So looks like you had to exclude some many patients due to patients not meeting inclusion criteria. How many plasma users were excluded, just to understand sort of generalizability of your result and how they were different from the people who are included in your simulated trial?
So probably around half of the plasma users were excluded, but this was due to our very strict eligibility criteria. Earlier in the pandemic, there was a wide variability in how plasma was used to treat patients. So in the beginning, under the emergency access program and then later emergency use authorization, it was primarily used in the most severely ill patients. So it wasn't early in the course of disease. And so that was the main reason why we excluded so many plasma patients, because they were treated a week or more after having their first positive test and hospitalization.
Did you look at their characteristics and see how they were different from those people included in general?
They were more severely ill, since it was kind of being used as a last possible approach for treatment.
Makes sense. So 3 more questions came. Why did you include in the model, or didn't you include in the model number of other treatments other than convalescent plasma received by the patients, or did you exclude patients with multiple therapies?
So we tried to include other treatments that were being used at that time. So we did look at glucocorticoid and remdesivir use, and also looked at use of supplemental oxygen. But beyond that, we were excluding severely ill. So those who were intubated or on dialysis, ECMO, were excluded because they were severe.
Okay. Another one says, please excuse my curiosity as I'm not from US, just curious about VA data. Does it include such young individuals from 21 to 80, or is it the family members or veterans? He's asking about distribution of the age among those who you included.
So we did include only veterans, and we limited to patients who were 80 or younger, because prior studies had suggested that the plasma would be most effective in a somewhat younger age group, despite the veteran population being old.
Okay. Another question, do you think the exclusion may violate the assumption on exchangeability and positivity?
So we actually believe that it helped to improve exchangeability and positivity, because we know exactly who's being included in the study, and making sure that there's that the patients within both treatment groups meet that criteria.
Last question here, was there heterogeneity in how receipt of convalescent plasma was captured in the EHR?
I don't believe there was, in terms of how it was captured. So we received data on convalescent plasma from 2 sources: the pathology pathology lab within the VA, and also from the Mayo Clinic's Expanded Access Program database. So we believe between those 2 sources, we are able to capture have pretty complete capture of the exposure for convalescent plasma.
So you think your capture was close to 100% or maybe 90%, something like that?
I believe so, yeah.
Okay. Yeah, I'm asking because my experience with the N3C data, I think they weren't captured very well. So it depends on the system and then EHR data. Makes sense. Yes, this is the last question.
Yeah, we had to receive, sorry, just to add a little bit more to that, we had to receive a list of patients who received the treatment. It wasn't actually, we weren't actually able to capture it within the electronic health record data. Like, there's not a procedure code or anything like that for it. So.
Right. Makes sense. So you targeted on non-severe COVID-19 patients, right? But you saw significant amount of patients on steroids. which is supposed to be used for kind of a more severe sort of COVID-19 patients. Do you have any comments on that?
Sure. So we did the best that we could using electronic health record data to develop an algorithm to identify patients with non-severe COVID illness. And so we really focused on excluding patients based on receiving treatments such as intubation, ECMO, dialysis, and making sure we excluded them. We also tried to use oxygen saturation levels to try to identify patients that were less severely ill. So that's why we required that the most recent measure of oxygen saturation had to be at least 90%. So we believed if it fell below that, it would be more severely ill, but it's not perfect. So probably we did capture some patients that may have not been had some severity or increasing severity of illness.
Makes sense. Great. Thank you very much. Very nice presentation and great discussion.
Thank you.
Danny, since the fifth speaker is not here, should we conclude?
Yeah, I think we can conclude thanking all the speakers and everybody who has asked questions and contributed to the discussion. Yeah, thank you everyone. It's a shame that we missed one of the speakers, but such is life in 2021. Thank you all.
Thank you.